Become a better doctor. Streamline the learning process with over 60 hours of organized, high-yield content. Subscribe now to get access to our premium content.
Peds Psych 2 behavior is about a couple of the disorders that might come up on pediatrics related to psychiatry. We're going to talk about elimination disorders, and elimination disorders certainly are not unique to pediatrics, but it's often where the question comes up. And then we'll finish off with oppositional defiant and conduct disorder, comparing the two. Let's start off with bedwetting and enuresis. Enuresis is defined by repeated urination on bed or clothes. Now, a psychiatric patient who's acting out might urinate on their pants. Right? Older, demented patients may be incontinent and need a diaper. But we're going to talk about kids here in bedwetting, in particular nocturnal bedwetting. So enuresis in general can be voluntary, that is, someone acting out. It may be an anatomical defect. Medications can do it, cause incontinence or frequent urination so that the patients miss or are unable to make it to the bathroom. Certain disease states can do it. But in psychiatry, where we're going is regression. And regression usually happens in kids with a new sibling or abuse. And for the test, if you see regression, you should think of abuse. And the same thing, regression can be seen as an elderly demented patient becoming incontinent and needing diapers as they age. But if a kid comes in wetting the bed, especially at night, the first thing you want to do is ask, were they ever dry? Get a history. Because if they were never dry and they're less than 7 years old, that's normal. All you need to do is training. And they may not need toilet training in general. They may just need nocturnal assistance. Right? It'd be weird for a 7-year-old boy to be going to school wearing a diaper. But it's not abnormal up until age 7. Usually happens around preschool years, especially the toilet training, but the nocturnal portion may take a little bit longer. And so what you can do in order to help them stop wetting the bed at night is use positive reinforcement. Never use negative reinforcement. It almost always fails. Positive reinforcement is required. Encourage the kid to try more, and even if he fails, tell him not to worry about it. If that doesn't work, you want to get them dry through the night, so you might do some water restriction and have them void prior to going to sleep. That is, that they won't have to urinate throughout the night. That won't help them train, but it'll give them the confidence that they can stay dry. And then you can do things like alarm blankets, training the kid to get up. When he feels the urge to void, either hold it in or go take care of business. Ultimately, but probably going to be the wrong answer on the test, you can use vasopressin, DDAVP, which will reduce the amount of urine created throughout the night. Again, all that's going to do is not help them with their training, but it'll keep them dry. If, on the other hand, they were ever dry, and now they're not anymore, something has gone wrong. That's a functional problem. And what you're going to do is get a urinalysis and an ultrasound. If you've got a positive urinalysis and a negative ultrasound, that's probably going to be infection. This happens with girls in particular. As they begin to toilet train, they wipe up, and they wipe stool into the vagina and the urethra. That's okay. If it's a regular UTI, then you just give them some antibiotics and tell them not to do that. But all the while, if you're thinking UTI and infection in a young girl, consider, is there the presence of a sexually transmitted disease? Because if so, that's abuse. And the test loves to bring up abuse issues in the setting of bedwetting. If the urinalysis is negative, but the ultrasound is positive, now you have an anatomical defect. Depending on what the anatomical defect is, you might do a biopsy or resection or somehow otherwise surgically correct. But the answer is probably going to be surgery. We have more on this in the Peds renal section. If the urinalysis and the ultrasound are both negative, then what you're left with is simple regression. And then it's your duty to find out what is the stressor, what do they care about. New sibling, new place, that's normal, let them grow out of it. But always remember, if you see regression, think about abuse, because the test loves to test ways of getting to abuse, and regression of someone who was once dry and has no anatomical or functional reason why they should be bedwetting. The bedwetting, the regression, may be the symptom of abuse. If we talk about encopresis, that means the same thing but stool. Same thing, psych patient can take a shit on the bed, and old people may get demented and become incontinent and need diapers. Young kids need diapers as they grow, and eventually they get toilet trained. Either it's voluntary or not. Regression, same thing. It's basically the exact same process, only with stool, so I'm not going to repeat it. Just remember that stooling may also be from a fistula, in the sense that it's not coming out of their anus, it's coming out of a fistulous tract. I want to close by comparing conduct disorder to oppositional defiant. Someone who has oppositional defiant is not all the elements of conduct disorder. It's sort of an elevation or an escalation from oppositional defiant to conduct to antisocial personality disorder. But it's not literal, right? Someone who has oppositional defiant will not become conduct. But someone who has conduct disorder may not have yet met the requirements, and it looks like oppositional defiant because they haven't done the things that categorize it as conduct. See what I mean? It is not a progression of a disease that if you intervene early, you can prevent it from happening. They're two completely separate disease processes, and this is how I want you to see these disorders. Conduct disorder is the criminal. But they're less than 18, they're juvenile, so you can't say that. Oppositional defiant is the teen acting out. Conduct disorder hurts peers and fights authority. Oppositional defiant fights authority. Thus the similarity in why they're often tested against each other, but cooperates with peers. We'll see how this plays out. Let's do conduct disorder first because it's a little harder and a little longer. The pathology of conduct disorder is effectively antisocial personality disorder. But because they're less than 18, they can't be diagnosed with a personality disorder. What you're going to see out of conduct disorder is bullying, destruction, and rules violating. Rules violation, you'll see things like truancy, running away from home, at least twice, and they'll be defiant of authority, police, teachers, parents. They destroy property, setting fires, and they will lie, cheat, and steal. Where conduct disorder really comes out is in the behavior towards their peers. These are the bullies. The buzzwords you're looking for are those people who hurt animals, use torture or cruelty to each other, to animals, or those who force sex. These behaviors, especially in the bullying of the peers, is going to be the thing that tips you towards conduct disorder. These are the criminals that need to be detained. The diagnosis is clinical. The treatment is juvie. Juvenile detention is oriented at reintegrating these people into society before they get full-blown antisocial personality disorder. Rehabilitation. If they make it into the system at 18 and they go into prison, it's more about detention and removal of rights and punishment. Juvenile detention is meant to try to change the course of their lives. But they need to be locked up because of all the damage they do and how much they hurt people. Let's compare that to oppositional defiant. The pathology here is incongruent parenting. They are going to lie, cheat, and steal. They are going to be defiant to authority, police, teachers, parents. But they don't hurt their friends. There's no bullying. There's no harming animals. There's no cruelty or torture. These are the kids who are often portrayed on TV as the skater punks who hang out under the bridge, right, smoking cigarettes and hanging out away from their family. They don't commit crimes, they don't hurt other people, they're just off on their own, but they're defiant of authority. The diagnosis here is also clinical. And the treatment has nothing to do with the kid, it's teach the parents how to parent. Unified front. Even if you disagree about something, parents should display that the parental unit is whole in any decision they make to give the kid an idea that there is an authority figure. It's believed that incongruent parenting can lead to oppositional defiant. Even that's not the only way to get there, but generally what I think of is the kids who are just acting out against their parents and authority because they're teenagers who don't do any harm, versus the people who are criminals who are hurting people because they like hurting people. And then as we round it out, enuresis, especially nocturnal, use positive reinforcement and always keep an eye out for abuse. That is Peds Psych 2 behavior.
Become a better doctor. Subscribe now to get access to our premium content.